Forgotten Elvis with music and vocals by Pandit W.J. Amradeva, adding a heartfelt cultural note to our program. So let us sit back and enjoy this soulful performance.
Isuru suwada rendu rendu, isuru suwada rendu rendu. Randadiya bindu bindu, isuru suwada rendu rendu. Katini hala, gayamu rangoyame sindu sindu. Rangoyame sindu sindu, rangoyame sindu sindu. Beteran malalu dange gela bandiran malage rangoya me nelana nage siriya vai ratata mage Beteran malalu dange gela bandiran malage rangoya me nelana nage siriya vai ratata mage Landu landu, nilum kete landu landu, sonduru kinduru landu landu, sonduru kinduru landu landu, nilum kete landu landu, sonduru kinduru landu landu. Devi pihiten kayamu rangoya me sindu sindu, rangoya me sindu sindu, rangoya me sindu sindu. Dutti mitole mata novedo mukulu kale rangoya me nelana kale mana benduna pabulu ele Dulate rata dutti mitole mata novedo mukulu kale rangoya me nelana kale mana benduna pabulu ele Randadiya bindu bindu, randadiya bindu bindu. Isuru suwada rendu rendu, isuru suwada rendu rendu. Randadiya bindu bindu, isuru suwada rendu rendu. Katini hala, gayamu rangoyame sindu sindu, rangoyame sindu sindu, rangoyame sindu sindu, rangoyame sindu sindu, rangoyame sindu sindu. Thank you very much.
So many thanks to Dr. Shantima Siritunga and Samita Siritunga for that soulful and uplifting performance. Your harmony, both as brothers and as a public health specialist, have added a beautiful cultural dimension to this evening's program. And ladies and gentlemen, we now return to the academic proceedings, one of the most esteemed segments of our inauguration, the Professor Dulita and Fernando Oration 2025 of the College of the Community Physicians of Sri Lanka. This oration is held in honor of one of the most revered figures in the field of community medicine, Professor Dulita and Fernando, a visionary whose contribution have left an everlasting mark on public health education, practice and policy in Sri Lanka and beyond. So each year, this oration brings to the forefront a topic of profound public health significance, delivered by a leader whose voice and vision continue to shape the national discourse. The theme for this year's oration is Strengthening Child Survival through Community-Based Interventions, a Public Health Imperative, a topic that lies at the very heart of our collective mission and resonates deeply with our commitment to protecting the most vulnerable among us. So it is now my great honor and privilege to cordially invite the orator, Dr. Renuka Jayatissa, a board-certified specialist in community medicine and an inspiring figure in field of public health, to gracefully ascend the stage. I also invite the conference chair and the Global Public Health Summit 2025 and the president of the College of the Community Physicians of Sri Lanka, Dr. Kapila Jayaratne, to kindly come forward to recite the citation of the orator and also to bestow upon Dr. Jayatissa the Orator's Medal in recognition of our outstanding achievements and the honor she brings to this occasion.
I want to thank CCPSL Council for accepting my suggestion to name the college Oration in the name of our pioneer president, Professor Dulita Nandani Fernando. So then came who is going to be the first person to deliver this oration. So we had a committee, and the committee decided that it should be delivered by one of her, Professor Dulita's distinguished students. And among the candidates, here comes the number one, Dr. Renuka Jayatissa. Congratulations, madam. So, Dr. Jayatissa currently serves as the Vice Chancellor of the International Institute of Health Sciences, IIHS, Multiversity, and Head of the Faculty of Food Science and Nutrition. She holds several prominent regional and international positions, including South Asia Regional Coordinator of the Iodine Global Network, President of the SARC Foods Association in Sri Lanka, Regional Coordinator for the South Asia Association of Parenteral and Enteral Nutrition, and Technical Trustee of the Emergency Nutrition Network, UK. She also practices as a visiting nutrition specialist in several private sector hospitals in Colombo. A graduate of the University of Colombo, Faculty of Medicine, Dr. Jayatissa holds an MD and MSc in Community Medicine from the Postgraduate Institute of Medicine. She completed further specialized training in public health, nutrition, and at the London School of Hygiene and Tropical Medicine, and in clinical nutrition at the Royal London Hospital. With over 35 years of experience in the public health sector, including work with the Ministry of Health, UNICEF, and other international partners, Dr. Jayatissa has led more than 25 national nutrition surveys, developed evidence-based policy, and shaped national nutritional indicators. She has been a trailblazer in translating data into impactful programs across Sri Lanka, particularly in maternal and child nutrition, micronutrient deficiencies, obesity, food security, and emergency nutrition response. As former head of the Department of Nutrition at the Medical Research Institute, MRI, she was the pioneer behind the establishment of postgraduate clinical nutrition training in Sri Lanka and led the development of MSc and MD programs at the Postgraduate Institute of Medicine. Over the years, she has mentored more than 300 postgraduate trainees in clinical nutrition and community medicine. A profile researcher, Dr. Jayatissa has authored over 100 peer-reviewed publications that have informed policy and practice at national and global levels. She is also the principal author of Sri Lanka's National Food Composition Tables and has developed Recommended Daily Allowances (RDA) for the Sri Lankan population. Her leadership extends to more than 30 national committees, including the National Nutrition Steering Committee, Food Advisory Committee, Codex Subcommittees, and the NCD Council. She continues to contribute actively to public health governance, curriculum development, and nutrition regulation. Dr. Jayatissa's lifelong service has been recognized through numerous awards, including the Presidential Research Award, Sir Marcus Fernando Oration, and honorary fellowships from the College of Community Physicians, the Postgraduate Institute of Medicine, and the European Society for Parenteral and Enteral Nutrition, (ESPEN). Madam, it is with honor I invite you to deliver the prestigious Professor Dulita and Fernando Oration of College of Community Physicians of Sri Lanka tonight. Thank you.
Good evening, ladies and gentlemen. President, College of Community Physicians, Dr. Kapila Jayaratna. President, Commonwealth Medical Association, Professor J. Jailal. Minister of Science and Technology, Professor Prashant Abesena. And Dr. Nihal Abesina, Member of Parliament. Honorable Chief Justice, Mrs. Lady Murdu Fernando, Vice Chancellor, University of Colombo, Professor Indika Karunatilaka, Dean, Faculty of Medicine, Professor Vachadu Dissanayaka, Keynote Speaker, Dr. Zivai Murira, past Presidents, Fellows, Council Members of the College of Community Medicine, my teachers, dear esteemed colleagues and friends. I consider it is a great honor and privilege for selecting me by the President and Council to deliver the first oration of the Professor Dulita Fernando. Thank you, President and Council members. Emeritus Professor Dulita Nandini Fernando was a pioneer in public health and community medicine in Sri Lanka. She graduated from the University of Ceylon in 1968 and began her academic career at the University of Colombo in 1970. She obtained her diploma in tropical public health in 1973 and completed a PhD in public health nutrition in 1973 from the University of London. Her career spanned over 4 decades, during which she served as head of the Department of Community Medicine from 1984 to 2005, and later as Dean of the Faculty of Medicine from 2005 to 2008. At the time of her retirement in 2010, she held the position of Chair and Senior Professor of Community Medicine. Professor Fernando also served as chairperson of the Research and Higher Degree Committee of the Faculty of Medicine from 1993 to 1999. She was a member of the Planning and Development Committee and the Board of Management of the Development Studies Institute at the University of Colombo. As Dean, she provided visionary leaderships to initiate the physiotherapy degree program at the Faculty of Medicine. An exceptional public health professional, Professor Fernando served as chairperson of the Board of Study in Community Medicine at the Postgraduate Institute of Medicine, University of Colombo from 1992 to 2000. Her contributions to curriculum development in community medicine and other allied specialties were highly influential and widely recognized. She was the founder president of the College of Community Physicians of Sri Lanka and also held leadership roles in several other professional associations, including the Sri Lanka Association for the Advancement of Science, the Nutrition Society of Sri Lanka, and the Sri Lanka Association of Community Medicine. She served in numerous national and international committees of the Ministry of Health and many UN agencies. Professor Fernando received several prestigious awards for excellence in teaching and research. Her impressive body of research has significantly contributed to the translation of public health evidence into practice in Sri Lanka. She was honored with fellowships from the Sri Lanka Medical Association, the National Academy of Sciences, and the College of Community Physicians of Sri Lanka. Her mentorship was deeply impactful, guiding and inspiring generations of students and professionals in public health. Her unwavering commitment to education and mentorship fostered critical thinking and a deep sense of community service among her students. On a personal note, Professor Dulitha Fernando was my teacher during both undergraduate and postgraduate training. Not only the supervisor of my MD thesis, but also my husband's thesis. And she was my lifelong mentor. Her guidance and unwavering support empowered me and in turn enabled me to uplift others. My family were always happy to visit her, drawn by her warm and kind nature. It is with deep sorrow that I note Professor Dulitha was not able to receive her final Presidential Research Award. In closing, I would like to acknowledge that Professor Dulitha was fortunate to have a loving and devoted husband, Mr. Sunil Fernando. Unfortunately, today he is not with us. He has some other commitment. Today, as I present the work I have carried out over the past 35 years in the field of public health, I do so with deep gratitude. Much of this journey was shaped and strengthened by the guidance, mentorship, and collaboration of Professor Dulitha Fernando. She has created everlasting professional impact and improvement of public health of Sri Lankans. My oration topic is Strengthening Child Survival through Community-Based Interventions, a Public Health Imperative. Under-5 mortality and infant mortality and neonatal mortality rates have significantly declined in Sri Lanka, as illustrated in this slide. Currently, all three rates are comparable to those in the United States. However, a major concern remains. The majority of child deaths are concentrated in children under 1 year of age, with nearly 2/3 occurring within the first month of life. Addressing this early neonatal mortality continues to be a critical challenge. Lancet has reported that malnutrition is associated with 60% of under-5 mortality globally. In Sri Lanka, although under-5 mortality has declined over the past 20 years, national surveys data show that child malnutrition has remained persistently high. As shown in this slide, 13% of children under 5 years of age are stunted, a rate that has not improved much over the last 2 decades. The low birth weight rate has followed the similar trend. Recent findings published in Nature highlight that malnutrition associated with increased risk of disease, impaired cognitive development, and mortality begins earlier than previously expected. The study emphasizes the children with multiple growth impairments were found to have significantly higher mortality rates from birth to 2 years of age compared to those without such deficits. Currently, most childhood nutrition interventions begin after 6 months of age to avoid interfering with exclusive breastfeeding. However, findings of this study suggest that if public health interventions are not delivered before 6 months of age, it may be too late to prevent stunted growth. As we are all aware, in public health, immediate interventions are essential. But equally important are long-term, sustained investments in public health strategies to ensure optimal child survival. All children have the right to survive and develop their full potential. Within this, every mother and child have the indivisible right to equitable quality health care. This is what public health interventions are important, because they are organized efforts to improve the health of populations or communities. Similarly, a career in public health offers the opportunity to make a tangible difference in the lives of countless individuals. This slide illustrates the public health interventions model, emphasizing that public health interventions are considered population-based when they operate across all levels of practice. These levels are represented by the 3 inner rings: system focus, community focus, individual and family focused. Together, these levels ensure a comprehensive and layered approach to improving health outcomes at scale. The public health interventions that I present today shows all levels of practices, providing insight into what works and to demonstrate their potential, even indirectly, for rapid and substantial impact in sustaining child survival. These interventions include community-based management of malnutrition, universal salt iodization, multi-sectoral programs in empowering communities. Each of these interventions play a critical role in strengthening child survival by addressing underlying nutritional and developmental risks during key stages of growth. In my professional capacity, I have been involved in these interventions by offering either technical guidance or conducting research to streamline implementation. The first public health intervention that I am going to discuss is community-based management of malnutrition, which was initially introduced under the name Nutrition Rehabilitation Program, named NRP. This program was first implemented in the conflict-affected areas of the north and east of Sri Lanka. In 2004, a study was conducted in the Mullaitivu district of the Northern Province at the height of the conflict. It was carried out with the support of central and district health staff in collaboration with the World Food Programme, which was led by Visakha Telagaratne. Remarkably, the study was also supported by the LTT, enabling a complete census of all children under 5 in the district. I would like to acknowledge the late Dr. Sibyl Vijay Singh from the Family Health Bureau, who accompanied us despite the tight security measures. She appears in this photo, which was taken at the time at the MOH office in Mullaitivu. A total of 12,271 children under the age of 5 were included in the study. The results revealed that 2.8% of the children were suffering from severe acute malnutrition and 21.6% were wasted. According to WHO criteria, these levels constituted the public health emergency, requiring urgent intervention to prevent child deaths. Subsequent assessments were conducted in 2006 among displaced population in the Trincomalee and Batticaloa districts of the Eastern Province and supported by the UNICEF. This slide shows the alarming pattern of severe acute malnutrition and wasting among children under 5 years living in these displaced communities. In Batticaloa district, the prevalence of wasting was 34% and severe malnutrition was 5.3%. While in Trincomalee district, the prevalence of wasting was 23%. Considering the critical context of the emergency situation, the first protocol for treating children with severe acute malnutrition using ready-to-use therapeutic foods, including BP100 and Plumpynut, was developed with the support of the dedicated group of experts. The steering committee included community physicians Dr. Sudachani Fernandes from the Family Health Bureau and Dr. Shanti Gunawardana from the Nutrition Directorate, pediatrician Dr. Shanti Mala De Silva from Lady Ridgeway Hospital and the late Dr. Chandrani Piasena Nutrition Unit at MRI. One of the next major challenges was training district health staff. Due to limited accessibility, the medical officers of maternal and child health in Batticaloa, Dr. Navalochitha, Trincomalee, Dr. Gunalan, Jaffna, Dr. Kethiswaran, Kilinochi and Molathiv, Dr. Satyamurthy, took on the responsibility of training staff to implement the nutrition rehabilitation program at the district level with the support of UNICEF health staff in districts, Sudharman and Gauri. I would like to appreciate their dedication and commitment. At the time, I was working with UNICEF and was able to provide both technical and logistical support to these 5 districts through the easily accessible UN system. The first consignment of RUTF was distributed through the World Food Programme's logistics network. However, the second container of RUTF was seized by the government army forces in Vaunia. Subsequently, the Health Secretary, late Dr. Atula Kahandaliyanige, and I were questioned by the Criminal Investigation Department under suspicion that the RUTF shipment was intended to support the war effort. Jaffna district faced significant challenges due to the closure of the A9 route, which caused food prices to skyrocket. At a review meeting in 2007, Dr. Kethiswaran presented the district's progress as summarized in this slide. 29,698 children were screened, representing 72% of the under 5 population in Jaffna district. The prevalence of wasting was 30.5% and severe wasting was 6.7%. Following the initiation of the NRP, wasting was reduced to 19% within 3 months. This was our independent assessment for Jaffna district, which showed that wasting had reduced from 19% to 10%, a level lower than the national prevalence at the time. In conclusion, it was stated that the Jaffna Nutrition Rehabilitation Program achieved a strong short-term impact with high coverage and good recovery rates among children with acute malnutrition. Soon after the war ended, the RUTF container was released, making RUTF sufficiently available to initiate the nutrition rehabilitation program for displaced children suffering from severe acute malnutrition, starting from the very first month. I had by then returned to the Ministry of Health and was able to conduct 3 assessments among the displaced populations living in camps in collaboration with UNICEF and WFP. Immediately, these assessment were immediately after the end of the war, at the middle assessment, and just before resettlement as shown in this slide. These are the few graphs that I have extracted from these studies. The prevalence of wasting decreased from 35.6% to 13%, and severe acute malnutrition declined from 8.8% to 1.9%. This success was the result of the collective effort by the Ministry of Health involving both central and district level staff under the supervision of the Family Health Bureau. The program was supported by all UN agencies in a well-coordinated manner without duplication of activities. Community mobilization was carried out by NGOs such as Sarvodaya led by Dr. Vinyari Ratna, Plan International led by Dr. Kalana Piris, World Vision, etc. Inward management of children was handled by hospital staff led by pediatricians. This data was presented during the Geneva Human Rights Inquiry to demonstrate that individuals from the north and east were not subject to discrimination and were afforded equal treatment as those in the rest of the country. What is the relationship between the nutrition rehabilitation program and child survival? Here are the few children we met during our assessments. You can see clear cases of both kwashiorkor and marasmus. Without timely intervention, we know what their fate would have been. This highlights the critical role of the NRP in saving lives. It may well be one of the key reasons why the decline in child mortality in Sri Lanka was not disrupted even during periods of intense conflict, possibly due to the effective and timely management of children with malnutrition. In 2012, the National Nutrition and Micronutrients Survey revealed that the prevalence of wasting was above 15% in all districts except Puttlam, and the rate of severe acute malnutrition ranged from 0.4% to 6.1%. In response to these findings, new protocols were developed, and a decision was made to scale up the program island-wide with the support of UNICEF. The program has expanded significantly. However, the Ministry of Health continues to import the high-cost BP100, with procurement supported by the willingness of donors. Two acceptability studies conducted in 2010 and 2023 showed that a locally produced formula is well accepted. In 2010, there was no private food producer available to manufacture the product due to the limited volume of supplies required for the country. This slide presents an alternative product to be developed for children with moderate wasting. Unfortunately, it could not be pursued further due to internal challenges and differing perspective among colleagues. At present, an effectiveness trial is not needed, as the composition is already well tested and has demonstrated positive outcomes. However, there may be a need to assess the bioavailability of the raw materials used in the local ingredients. The main challenge now is identifying a private sector partner to sustain local production of the product. What are the lessons learned from this public health intervention? This is one of the successful public health interventions implemented by the public health system of the Ministry of Health. The success is due to many factors, such as continuous updating of the SAM protocol, follow-up research, use of real-time results, strong networking, commitment of trained public health staff, effective support from donors and NGOs, and the involvement of mothers. The community-based management of acute malnutrition approach proved to be life-saving and scalable, reaching children in remote and conflict-affected areas. It enabled timely identification of children with SAM through regular screening by public health staff. This was a cost-effective intervention, significantly reducing the burden on hospitals and families. It also empowered caregivers, particularly mothers, by involving them in the solution, rather than positioning them merely as recipients of food aid. In the Sri Lankan context, where conflict and displacement disrupted access to healthcare, NRP provided an effective mechanism to reach the unreached, restore child health, and rebuild trust in the health system. The availability of real-time data and results created opportunities for the program to be scaled up nationally and sustained over time. After highlighting the need for private sector involvement in the previous intervention, I would now like to present a second public health intervention that successfully demonstrated effective public-private partnership at the Universal Salt Iodization Program. According to the World Health Organization, iodine deficiency disorders, which can begin even before birth, threaten children's mental development and in severe cases their survival. Serious iodine deficiency during pregnancy can lead to stillbirth, spontaneous abortion, and congenital abnormalities such as retinism, a severe, irreversible form of mental impairment. A goiter belt was identified in Sri Lanka, primarily covering the wet zone of the country as shown in this slide. When I was working at the Red Ridgeway Children's Hospital in 1986, it was common to see children with cretinism admitted to the ward. A landmark study conducted by late Professor Malcolm Fernando, Professor of Community Medicine at the University of Peradeniya in 1986. The study revealed that 19% of school children were affected by goiter. As a result, iodine deficiency was recognized as a major public health problem in the country. In response, the Ministry of Health launched the Universal Salt Iodization Program in 1995 under the provision of the Food Act. After returning from my foreign training in 1999, I took on the challenge of establishing the iodine laboratory. At the time, this was a difficult task due to recurring issues with contamination. With the support of the late Dr. Melayanthi Gunathilaka, chemical pathologist at MRI and UNICEF, the laboratory was successfully established. Staff were trained and accreditation were achieved through the CDC Atlanta EPIC program. This enabled us to conduct the first national iodine survey in 2000. This slide shows the child we found during the survey with a visible goiter, and overall goiter rate was 21%. Although all provinces were iodine sufficient, the Uva province was iodine deficient, while the North Central province had more than adequate iodine levels based on median urinary iodine concentrations. It was found that iodine levels in drinking water were high in the North Central province due to hard water. A prominent finding was the varied iodine content in salt, caused by improper mixing and inconsistent addition of iodine, as shown I will show the pictures later. This highlighted the importance of regular monitoring. At that time, SLMA presidents, Professor Chandrika Vichyaratna and Professor Vachata Dissanayaka played a key role in advocating for the study's findings to help streamline and ensure uniformity in salt iodine levels. I have delivered SLMA Oration on iodine during this period. Subsequently, national surveys were conducted every 5 years, with a total of 5 surveys completed. As shown in this slide, all assessment was supported by UNICEF. As recommended by the WHO, 3 indicators were monitored. The first was the goiter rate, which declined to the target level of less than 5% by 2005. Median urea iodine concentrations remain within the normal range throughout the period. However, the proportion of households using adequately iodized salt has been below 90% since 2010. Successive directors of the Food Administration Unit of the Ministry of Health have used the survey results to enhance the monitoring of iodized salt. This included changes to regulations through updated gazette notifications to address variations in salt iodine levels. I would like to acknowledge the dedication and extensive coordination of the Directorate of Environmental and Occupational Health and community physicians, as well as the country's extensive network of public health inspectors. The members of the Food Advisory Committee also supported this initiative wholeheartedly. Over the years, many changes have taken place in iodized salt production. You can see in this slide. Salt manufacturers transition from manual to automated systems for iodine addition, leading to improved quality of iodized salt as shown in these pictures. This slide shows the finding of the most recent assessment conducted in 2022. The results were alarming, indicating low iodine status across all population groups. Particularly concern was the iodine insufficiency observed among pregnant women. Such setbacks are not unusual in long-standing public health programs, especially during times of national crisis, such as the COVID-19 pandemic and the recent economic downturns. The most important aspect is acknowledging the problem and taking corrective action. Often when results like these are published, there is the tendency for authorities to question the findings, citing poor sampling methods or inaccuracies. However, the Food Control Directorate responded positively, investigating the root causes. It was discovered that salt producers were adding lower levels of iodine to avoid exceeding the maximum permitted limit set by the Gazette, in order to avoid penalties. Following this, several discussions were held with salt producers, and Dr. Jayalal's team initiated efforts to amend the Gazette. This situation provides a valuable lesson in the long-term sustainability of public health interventions. The Food Control Directorate has launched iodine sentinel surveillance among pregnant women with the support of the Iodine Global Network in 2023 and repeated in 2024, showing encouraging progress. Furthermore, Dr. Kitsiri Edirisinghe, visionary leader, established the CDC accredited reference laboratory at IIHS to support this surveillance program, further strengthening public-private collaboration. These are the few publications produced over the years, documenting the progress of the program and the challenges encountered. What lessons have we learned from this highly successful public health intervention in Sri Lanka? First, strong public-private partnerships are essential. Sustaining a universal public health intervention requires close collaboration between the public and private sectors. In the case of iodized salt, private sector producers implemented the intervention while the public sector provided oversight, guidance, and support. Second, the government as a regulator and enabler. The government's role should not be limited to enforcement. Instead, it must act as both the regulator and a facilitator, supporting monitoring systems, updating regulations when necessary, and trusting the private sector to deliver on implementation. Third, effective intra-ministerial coordination. Within the Ministry of Health, effective coordination among various units, including food control, nutrition, ENOH, public health officers, was key to consistent monitoring and rapid response to emerging challenges. Fourth, research-driven decision-making. One of the most important lessons is the value of applying research findings to improve programs. Evidence from national surveys, sentinel surveillance, and laboratory data directly inform policy changes and strengthen the intervention over time. Fifth, resilience and adaptability. Setbacks such as decline in iron status in 2022 demonstrate the need for programs to be resilient and adaptable. The willingness to acknowledge challenges and course correct is vital for long-term sustainability. The third public health intervention I will present is the scaling up of nutrition through multi-sectoral program. Sri Lanka joined the scaling of nutrition movement in 2010, which was coordinated by Dr. Lalit Chandradas at the Presidential Secretariat under the leadership of Mr. Anuruddha Dissanayake. A national roadmap was developed, along with training manuals and standard operating procedures for the multi-sectoral committees. As shown in this slide, I had the opportunity to be involved from the beginning, serving as a technical advisor. The activities were primarily supported by UNICEF and other UN partners, who played a key role in advancing the program. I will highlight few activities. This slide shows the community-based complementary feeding program conducted by MOMC Chambantotta and the reduction of underweight in parallel to the intervention. Several factors positively influenced the success of this program, including the high level of commitment from health staff at all levels, including administrators, the dedication and participation of the mothers involved, the uninterrupted implementation of the program largely due to strict adherence to pre-planned schedules, the sustainability of the program without requiring additional funding. Feeding a child is never just about food. It is about knowledge, tradition, time, confidence, and care. Community nutrition promotion turns this daily act into a life-saving intervention. This slide presents another assessment conducted to evaluate the impact of the multi-sectoral program. It revealed changes in the prevalence of malnutrition across selected districts between 2009 and 2012. Except for stunting in all districts, low birth weight in the Badulla district and underweight in the Monragala district, the prevalence of most malnutrition indicators increased during this period. The highest increases in underweight, wasting and low BMI were observed in the Monragala district, despite it being an intervention area. Conversely, the largest decrease in stunting occurred in Nuwara district, where the intervention was also implemented. These findings indicate that further attention is needed to address maternal nutrition and the wasting of children to improve outcomes. Community-based health promotion model was implemented by the Foundation for Health Promotion under the leadership of Professor Diyanath Samarasinghe and Dr. Manoj in 5 districts. Rationale was, despite several years of implementing both food-related and health-related strategies in these districts, improvements remained limited. This highlighted the need for a new and more effective approach in which the community itself initiates, develops, and maintains activities that promote child nutrition and support children's mental and social development. This slide shows that the 15 activities initiated by them. One of the interesting activities was Vibhaga Pora, comprised of drumstick leaf and sprouts, to be added to each meal of the child. Recently, I met public health matron from Anuradhapura district and mentioned mothers still keep these bottles in their kitchen. And mothers feel children do maths well after taking this formula. Evaluation revealed that this program successfully built the capability of mothers, enabling them to creatively contribute to improving their children's nutrition. This empowerment allowed mothers to diversify their approaches and take ownership of solutions, demonstrating the value of community-led initiatives. In summarizing the lesson learned from these public health interventions, several key insights have emerged. These include the effective use of field research, the pivotal role of strong leadership, and the importance of delivery strategies that actively engage community level implementers. The success of these programs was also significantly influenced by clearly defined guidelines, robust system support, adequate resources, and effective coordination mechanisms. The purpose of today's oration was not merely to examine the outcomes of individual programs, but to highlight the common factors that contributed to their success. These shared elements play a critical role in advancing child survival and nutrition efforts in Sri Lanka, and they provide valuable lessons for designing, implementing, and scaling similar interventions in other settings. In conclusions, the decades of rapid decline in infant and child mortality in Sri Lanka also witnessed rapid expansion and high coverage of proven mortality reduction interventions such as community-based management of malnutrition, salt iodization, community empowerments. Socio-economic conditions were also changing during this period, and the decline in mortality resulted from overall improvements in incomes, education, and access to social services. However, evidence of successful scaling up of these programs clearly indicate that some substantial proportion of mortality decline can be attributed to child survival programs. Yet, challenges remain. Poverty, inequities, system weakness, and behavioral gaps call for our continuous vigilance and action. Through strong health systems, evidence-based policies, and empowered communities, we can bridge these gaps. Child survival is not the work of one person, one program, or one moment. It is the product of robust policies, resilient systems, and empowered communities. As a final note, I would like to emphasize that after our board certification as specialist, we often feel as though we know everything. However, I have come to realize that continuous growth requires the guidance of our mentors. Their support is essential for refining our skills and strengthening our competencies. These improvements have led us to international recognition. I am proud to be a public health specialist, as it allows us to collaborate across all clinical disciplines. Every disease, whether acute or chronic, requires interventions at the primary, secondary, and tertiary levels of prevention, and public health plays a central role in all of them. Clinicians help thousands, but public health specialists help millions to live healthier and happier lives. I would also like to sincerely acknowledge the support of my former colleagues at the MRI, as well as my husband Amal and my children Pumika and Hirun, who have stood by me throughout my career. My special thanks also go to the late Professor Dulitha Fernando, in whose name we deliver this oration today. Her dedicated involvement at the policy level was instrumental in achieving the public health milestones that we showcased today. Thank you for your kind attention.
Thank you very much, Dr. Renuka Jayatissa, for that deeply insightful and inspiring oration. So your eloquent reflections on strengthening child survival through community-based interventions have not only enriched our understanding, but also reignited a collective sense of purpose among all of us in the health community.